Assalamualaikum. I am Dr. Mahbub Alam, Assistant Professor, Current Charge, Department of Pathology, Bashundhara Ad-din Medical College. Welcome to today's video lecture. Today we are going to discuss about lymphoreticular system. So lymphoreticular system includes the lymphoid organs. As we know, there are two types of lymphoid organs. One is primary lymphoid organs and another is secondary lymphoid organs. Primary lymphoid organs are those organs where there are first lymphocytes are generated. So there are two types of primary lymphoid organs. One is thymus and another is bone marrow. In thymus, T lymphocytes are generated, and in the bone marrow, B lymphocytes and other blood cells are produced. Then there are secondary lymphoid organs. What are the secondary lymphoid organs? These are the organs where the cells are exposed to adaptive immune system. So these are the most important is lymph node, then there is spleen, then there are Peyer's patches, tonsils, Welder's ring, etc. So any enlargement or disease of the lymph node is known as lymphadenopathy. The causes of lymphadenopathies include either infectious cause or any connective tissue disorder or any neoplasm involving the lymph node. The infectious causes include the bacteria such as Streptococcus or tuberculosis. The viral causes include HIV or Epstein-Barr virus. The parasites may include the histoplasmosis or toxoplasmosis, etc. Then regarding the connective tissue disorder, there may be SLE or rheumatoid arthritis, or the patient may have a sarcoidosis or any case of amyloidosis, and some drugs may also cause lymphadenopathy such as phenytoin. And finally, the neoplastic diseases of lymph node. They may be either primary or secondary. The primary neoplasm of lymph nodes are known as lymphoma, or the lymph node may be secondarily involved by a tumor arising somewhere else. As we know, most of the carcinomas, they use for metastasis the lymphomatous pathway, so they are going to involve the lymph node. For example, any squamous cell carcinoma of the head neck region will metastasize to the cervical lymph node, and again the thyroid carcinomas will metastasize to the cervical lymph node and present as a lymphadenopathy. Now regarding lymphadenitis, that is the inflammation of the lymph node, they may be of two types. One, they may be acute lymphadenitis or there may be chronic lymphadenitis. The acute lymphadenitis may be due to the drainage of microbe or microbial product from a draining area of the region. For example, if the patient has an infection in the oral cavity or in the tonsil, the microbes or microbial product may drain into the regional lymph node such as cervical lymph node, and there may be secondary immune response and consequently enlargement of the cervical lymph node and the resulting acute lymphadenitis. Now acute lymphadenitis will present the way any acute inflammation present. So there will be pain in the lymph node and there will be redness over the lymph node and the lymph node will be enlarged. In case of chronic lymphadenitis, the duration of the disease is more prolonged and the symptoms of acute lymphadenitis are usually not there, and this usually present as a non-tender enlargement of the lymph node. They usually occur after a trivial injury and an immune reaction against the trivial injury. Now for our country's context, the tubercular lymphadenitis is very important topic for us. As we know, the tubercular lymphadenitis is the most common extrapulmonary presentation in a patient. So the patient will present as an enlarged lymph node with occasional low-grade fever and there may be history of cough. So in that case, what can we do? What sample we can take from the lymph node is, first we can take an FNA sample and under the microscope we can see the granuloma. We can do ZN staining and see the acid-fast bacilli. Next we can do the genetic test such as the gene expert test. and by this we can see the MTB is present or not, or whether the patient has resistance to the rifampin drug. And finally, we can biopsy the lymph node and see the granuloma under microscope. Now our next topic is regarding the lymphomas. We know that lymphoma is a malignant tumor of the lymph node which forms a mass produced by the neoplastic lymphocytes. The lymphomas are usually categorized into two different entities. One is Hodgkin lymphoma and another is non-Hodgkin lymphoma. The Hodgkin lymphomas usually always arise in the lymph node, but the non-Hodgkin lymphomas, most of the cases, about 2/3 of the cases arise in the lymph node, but the remaining cases arises in the extranodal area such as the Peyer's patch, GIT of the GIT, or maybe in the lung or thyroid, or maybe in the bone marrow. Now there is a classification of the lymphoma which is based on morphology, immunophenotypic, genotypic and clinical features. They are classified into 5 broad categories. Number 1 is the precursor B cell neoplasm, which includes the B cell acute lymphoblastic lymphoma. Second, there is peripheral B cell neoplasm, which includes Burkitt lymphoma, follicular lymphoma, etc. And third, there is precursor T cell neoplasm. Then there is peripheral T or NK cell neoplasm, and finally there is Hodgkin lymphoma. So regarding Hodgkin lymphoma, it usually affects a single lymph node or a single chain of lymph node. And morphologically, to diagnose a Hodgkin lymphoma, we have to identify the Reed-Sternberg cell. So there are two broad types of Hodgkin lymphoma. One is classic subtype, and then there is nodular lymphocyte predominant. In the subcategory of classic subtype of Hodgkin lymphoma, there are 4 types. The most common is nodular sclerosis, then there is mixed cellularity, then there is lymphocyte rich and lymphocyte depletion type. But the most common is the nodular sclerosis variant of classic Hodgkin lymphoma. To diagnose a case of lymphoma, first to be exact Hodgkin lymphoma, we have to first identify the RS cell, that is Reed-Sternberg cells. There are many types of Reed-Sternberg cells. The classic or diagnostic Reed-Sternberg cell is characterized by the following criteria. It will be a large cell with there may be multiple nuclei or a single nuclei with multiple lobe, and the lobes will have a large prominent nucleoli, and sometimes they have a mirror image appearance and are often termed as owl eye nuclei. There are other variants of RS cell apart from the classic or diagnostic RS cell. Those include mononuclear variant, lacunar variant and lymphohistiocytic variant. But doing only morphology by histological study is not enough. To diagnose a case of Hodgkin lymphoma, we have to do immunohistochemistry. By doing immunohistochemistry, the Reed-Sternberg cells in case of classic Hodgkin lymphoma will be positive for PAX5, CD15 and CD30 markers. And as we have mentioned, the patient will have clinically a enlarged lymph node, usually the cervical lymph node. The lymph node will be non-tender. The size will be usually more than 2 cm, and the patient may have another systemic symptoms called the B symptoms, which includes night sweat, fever and loss of body weight. So these are the clinical features of Hodgkin lymphoma. In case of non-Hodgkin lymphoma, most of them are from B cell origin, approximately 90%, and the rest are T cell origin. Unlike Hodgkin lymphoma, which almost always involves the lymph node, the non-Hodgkin lymphoma may be present at extranodal site, such as the bone marrow, the GI tract, the thyroid, the lung, the brain, etc. And the patient usually present with multiple enlarged lymph nodes. So the main difference between the Hodgkin and non-Hodgkin lymphoma are these. First, Hodgkin lymphoma is limited to a single axial group of lymph node, but non-Hodgkin lymphoma usually present with multiple involvement of the lymph node, and Hodgkin lymphoma spreads by contiguity. For example, if a patient has a Hodgkin lymphoma of the cervical lymph node, it will next go to the axillary lymph node, but this is not the case in case of non-Hodgkin lymphoma. And third, the Hodgkin lymphoma usually do not involve the mesenteric or Wilder groups of ring, but the non-Hodgkin lymphoma usually involves them. And the extranodal presentation or extranodal involvement are rare in case of Hodgkin lymphoma, but these are more common in case of non-Hodgkin lymphoma. And for diagnostic purpose, RS cells are present in case of Hodgkin lymphoma, but they are absent in non-Hodgkin lymphoma. So these are the topics that we have to read for the lymphoreticular system. First, we have to know the lymphoid organs, primary and secondary lymphoid organs. Second, we have to know the causes of lymphadenopathy. Third, we have to learn about the acute and chronic lymphadenitis, and more importantly, the tubercular lymphadenitis, how they present and how can we diagnose. And finally, the neoplastic diseases of the lymph node, which includes the lymphomas. We have to know about the clinical presentation of lymphoma and the WHO classification, and followed by the Hodgkin lymphoma, the clinical presentation and the various types of RS cells, and the immunologic or IHC profile of Hodgkin lymphoma, and the difference between Hodgkin and non-Hodgkin lymphoma. Thank you.